Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss-Studientelegramms, Marcus at Home welcomes Dr. Andrew Bomback in New York City, New York, USA, with whom we would like to discuss the issue of induction of novel or relapsing autoimmune kidney disease in people after SARS-CoV-2 vaccination. It's a pleasure to have you with us. Thanks for taking your time, Andrew.
Oh, thank you for having me.
So Dr. Bomback is a nephrologist who is specialized in glomerular diseases and resistant hypertension at the Department of Medicine, Division of Nephrology in Columbia University Irving Medical Center in New York City. He has just published a very interesting overview paper on the de novo and relapsing glomerular disease after COVID-19 vaccination. What do we know so far? Published in AJKD just some days ago. So he's really the one to ask how to handle this issue, what to tell our patients, and how to face this issue. So my co-moderators are Sören Becker from Hamburg, Germany, who specialized in infectious disease, and from Innsbruck, Austria, for the first time with us. A pleasure to have you, Andreas Kronbichler, who's also a nephrologist. My name is Gunnar Heine, nephrologist from Frankfurt in Germany.
Yes, hello from my side as well, and thanks very much for being with us, Dr. Bomback, today. So I think there's a growing body of evidence which you just nicely summarized with regard to autoimmune diseases in temporal correlation with COVID-19 vaccine. So maybe first to start off, could you please briefly summarize your findings, and then of course also get some opinion perhaps on whether that is really causality or rather coincidence.
Well, thank you. So the big question of causality versus coincidence, I think, is not perfectly answered now, but I think the evidence is accumulating enough that it seems more than just coincidence. So what we recently published as an editorial, but it's also essentially a review of the literature, which is constantly evolving. But the first 25 reported cases of glomerular disease onset roughly within 1 to 3 weeks of receiving a COVID-19 vaccine. Some of these cases are relapses of previously known glomerular diseases, for example, IgA patients. Some of them were de novo glomerular disease, first onset, for example, minimal change disease. And as we mentioned, it's a very rapidly evolving field. It seems like each week there's another 4 to 10 new case reports that seem to appear. And there are obviously a number of cases that have not been published. You know, in our own clinics here, I can count at least 3 or 4 patients with good stories that would fit the criteria for a relapse of their glomerular disease after a COVID-19 vaccine, most prominently IgA nephropathy patients getting gross hematuria. So I think it is a sizable entity, but I think the biggest thing we want to do with publishing these cases is really to inform nephrologists and caregivers and patients about this risk, which is small, but by no means do we want this to be a deterrent to undergoing vaccination. Because one of the things that we also, stress is that the virus itself has been linked to relapses of glomerular disease. And we use the example of anti-glomerular basement membrane disease. There have been more cases of anti-GBM disease that have been associated with COVID-19 infection than there have been associated with COVID-19 vaccine receipt. So by no means is these onset of cases meant to dissuade people from getting vaccine. It's more so that they're more aware of a very small risk, and that they and their physician can closely monitor for this. And in some cases, it can be very mild. If you have IgA nephropathy and you just get gross hematuria and that resolves within 2 to 3 days, that's not so different than what might happen after an influenza vaccine or after getting just a viral upper respiratory infection. But in some cases, it has been quite severe, including, very severe AKI in the setting of profound nephrotic syndrome with minimal change disease. So I think it's important for nephrologists to know this. I think it's something that we want to make sure we don't keep hidden from our patients. We want to be as transparent as possible. And I think it's something that will become another challenge in how we manage this pandemic, because I think it's very likely that many patients are going to get re-challenged with vaccine, and then that raises a whole other slew of questions. So those are sort of the big topics that we discussed in our article. One thing that we stress, and this goes back to your question originally of causality versus coincidence, is that there's still a lot of unanswered questions, including what is the precise mechanism by which these relapses are occurring, because some of these diseases, for example, anti-GBM disease, membranous nephropathy, ANCA-associated glomerulonephritis, these are clearly antibody-mediated diseases. So, you could point to B-cell stimulation as part of the pathogenesis, but something like minimal change disease, which is a podocytopathy, nobody really knows what the humoral mechanisms are that trigger that, but we would assume there's some sort of cytokine stimulation of injury. So it appears that there's not one sole route of injury for glomerular diseases in general. And the more we work towards elucidating that mechanisms, the better we might be able to get to that question of, is this true causality?
Okay, thank you very much. Is it possible, based on the very limited amount of case reports, to tell whether there's, not for de novo, but for relapsing disease, any specific risk pattern in terms of, be it age group or recent disease activity, or maybe also whether there's a difference between the different COVID vaccines?
Yeah, that's a great question. I think that the number of cases is too small to give risk factors based on demographics. Although the one thing I would say, and this is very specific to IgA nephropathy, that if you have the type of IgA nephropathy that is associated with gross hematuria at the time of infection. So if you have the type of IgA nephropathy where once a year or once every 2 or 3 years, if you get a bad infection, you have gross hematuria, I think that patient would be particularly primed to have gross hematuria after a vaccination. Likewise, if you've ever had gross hematuria after an influenza vaccine, then you would be more at risk for getting gross hematuria after a COVID vaccine. What's interesting is there's one case that was reported of someone who had gotten a reaction to a previous influenza vaccine. A previous zoster vaccine. So had an IgA flare after getting a zoster vaccine, and then 2 years later gets the COVID vaccine and also gets a flare. So I think obviously a previous flare after another vaccine is a risk factor. But whether or not it's preferentially affecting younger versus older, men versus women, certain race or ethnicity groups, I don't think we have enough data to make that sort of prediction. And then in terms of vaccine type, we're seeing it reported in the 3 main ones that are given in the United States are Moderna, Pfizer, and the Johnson & Johnson vaccine. But it has been reported in Europe with the AstraZeneca vaccine as well. So while it does appear to be, numerically more common in the Moderna and Pfizer routes of vaccination, it has been reported in the other vaccines as well. So I think it's, all of them carry some degree of risk.
Right, thank you. Maybe a last question from my side would be, beyond nephrology, I think there's also been isolated reports of cutaneous lupus, etc., associated with the COVID vaccination. So do you think that is a problem that's basically associated with every type of autoimmune disease, or is any specific pattern with regard to organ preference be seen based on the available data?
No, I think that's a very good question. I mean, I mean, I think that's probably, there probably could be a very, interesting parallel discussion amongst rheumatologists right now who are seeing some degree of flare in their patients who do not have renal involvement. So I don't think there's anything particularly unique to the kidney in terms of being a, sort of a sink for some of these immune responses. I mean, for example, we have seen a patient who had essentially IgA vasculitis with very minimal renal involvement, but very severe skin rash. And a biopsy was done of the skin that was conclusive for IgA vasculitis after a vaccine. And as you alluded to, there have been cases of cutaneous lupus flares. So I think, other autoimmune diseases are probably at similar risks for these kinds of flares. I think the kidney is an easy one to recognize because when the kidney is inflamed, it's pretty easy for us to detect that.
I'm taking on now, and it's also a great pleasure, first time to do the Marcus at home and having such a well-known expert in the field. We briefly had contact by email last year, but we don't know each other in person, fortunately, and hope that we can see each other soon in the States. So my first question is, in your experience, is there a higher risk after the first or the second dose of the vaccine? Or eventually the dose then? Yeah,
I think, so numerically, more of the responses, especially for, I think the biggest data is in IgA and minimal change disease. So you sort of take those as two separate entities. In IgA, almost all of the responses have come after the second dose. I mean, there have been a few case reports after the first dose, but the majority of the responses have come after the second dose. Interestingly, with minimal change disease, it's come after the first dose. So to some degree, that may correlate with the types of diseases that these two are. Like minimal change, a very abrupt disease. Like once it starts, it's clinically apparent. It's possible that with the IgA cases, the first dose is sort of giving some subclinical disease that's not apparent, and then it shows up after the second. But if you look at when they're being reported after the second vaccine. But I think it's reasonable to think that even if it's not being apparent after the first vaccine, there's some stimulation of the immune system that's occurring where the beginnings of the disease. Maybe if these patients were, if especially for de novo IgA, if you were doing, urinary tests for microscopic hematuria at that point, maybe you would have picked it up earlier.
Yeah, thank you. That's very plausible. So the next one is a bit out of the blue. As you know, we get more and more heterologous vaccine regimen. And are there any cases so far after, let's say, Johnson & Johnson plus then Moderna or AstraZeneca plus Moderna? Do you know anything about that?
No, that's an interesting question. And I have not seen any sort of response. What I have seen reported, and we've even seen it in one of the cases that we reported, is that re-challenge of the same vaccine has led to another relapse. So, for example, we had a minimal change patient who, after the first dose, had a very severe flare, was recovering, and then they re-challenged him and basically had almost identical flare. But I haven't seen anybody sort of mix and match where one vaccine is given for the first dose, the second vaccine is with a different, and then the flare. And in fact, that's one of the things we say may be a potential avenue in the future. If you got your flare or you got your disease onset from an mRNA vaccine, maybe if you need to get revaccinated, you should use an adenoviral vaccine, for example. I don't know if that's, we don't know until we have enough cases to actually try this strategy to see if that's a proven strategy, but that would be something that I think you would want to consider for patients who need to get revaccinated.
So the next one is a bit relying on this one as well. So you know that our patients are a bit a worsened response to vaccines, and in terms of risk of autoimmune disease, do you think that we should triple vaccinate our patient or at least an early booster dose?
Yeah, this is a really important question, and I think we don't have enough data now to really know what to do in this situation. So, for example, as you're alluding to, this third dose of vaccine, which has really been piloted in uh, transplant patients, particularly those who do not develop detectable antibodies after the second vaccine. Um, getting a third dose increases their chances of having detectable antibodies. I think we're going to know a lot more about how to categorize an effective immune response um, over time. So, I rely heavily on my infectious disease experts here who have said, and I'm paraphrasing them, but have said, that the 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 measurement of the anti-spike antibody is not the sole way to know if somebody has immunity from their vaccination. There's for example, T-cell mediated responses to vaccine that aren't quantified in that test, and patients who don't have detectable antibodies may still have some degree of immunity against the virus. Um, Surely not as robust as somebody who has concomitant antibodies, but um, still may have some degree of immunity. We're actually doing a study here at Columbia where we're doing what we call immune phenotyping of a number of different kidney populations to look not just look at antibody production, but to look at T cell function and to look at essentially the, the detailed immune response to the vaccine in different groups of patients. So we have a CKD non-immune suppressed cohort just to see if reduced GFR is affecting the immune response to the vaccine. We have a glomerular disease cohort of patients with glomerular disease who are not on any immune suppression, though, to see if just the glomerular disease itself affects the response. Then we have glomerular disease patients on immunosuppression. And then we have transplant patients who are on 2 immunosuppressions to see if there's a gradation. So we're one of, I'm sure, many centers who are doing these kinds of studies that are trying to sort of really profile what happens throughout the immune system, not just in terms of antibody productions in response to a vaccine. I think those kinds of studies will help guide us, for the next round to say, should these patients who don't develop antibodies after 2 doses get a third?
Thank you very much. And the last from my side is also a rather controversial one. So the American College of Rheumatology advised, for instance, to withhold MMF 1 week, or you can withhold MMF for 1 week after vaccination. But given the risk of disease relapse, and for instance, in immunochange disease, as you pointed out, wouldn't it be more secure to increase immunosuppression during the vaccination process?
Well, you guys definitely ask difficult questions. Well, I would say, I could just, there's no right answer to this. It's really sort of what each person is doing. I mean, for me, I do not modify the mycophenolate dose. I do not modify the tacrolimus dose. The one thing that I do actually routinely practice now is I will delay rituximab dosing until 2 weeks after the second vaccine, so that they've had a chance to develop antibodies. And if somebody has received rituximab recently, I recommend that they wait till about 5 months after rituximab to receive a vaccine. Just because I think if their B cells are completely depleted, it's going to be hard for them to get a response. But I know I've not modified the other immunosuppressants. And the other thing I would say is if somebody's on a high dose of prednisone, I've also recommended, if we know we're tapering it, wait till you're on a lower dose of corticosteroid before you get your vaccine, which is essentially what I've done with any vaccine in the past, just to try to, improve the chances of getting a good vaccine response. But I think this idea, if you hold mycophenolate a week before or a week after, I mean, with the way that drug works, it's hard to even be confident that you're going to necessarily be getting that much of a reduced immune response. And as you mentioned, there's also this risk of disease flare. So why do that? So, but again, I think this is one of those things where for too many years, we probably as a field have not really paid enough attention to vaccinations in general, where we routinely vaccinate patients on immunosuppression, and we routinely vaccinate patients with advanced kidney disease, and we've never really routinely monitored if they're actually getting a vaccine response. Even in clinical trial, for example, I do a lot of work in the complement area, and even in clinical trials that require a vaccine to be in the study. So like if you're going to be on a anti-C5 therapy or an anti-C3 therapy, where they say if you cannot be in the study unless you've been vaccinated against Haemophilus influenza, pneumococcus, and Neisseria meningitidis. All that's been required to be in those studies is actually just documentation that you got the vaccine. We've never actually required documentation that you actually responded to the vaccine, that you actually got a vaccine response. So I think as a field, we've been a little bit sort of overly, I would say like just overly optimistic about what vaccines are doing in our patients. And we probably are going to learn from this that we need, if we really want to make sure our patients are vaccinated, that we have some degree of measurement of vaccine efficacy.
So I would end up with two last questions that are also, I guess, quite difficult questions. And the first one goes back to the patient you reported of who had autoimmune disease after the first and then again after the second vaccination.
Yeah.
So if we treat these patients, and I just remember one young woman who had, after 7 years of really well-being, a relapse of her autoimmune disease after the first vaccination. If that's somebody who's not on immunosuppression, who may have a quite good answer after the first vaccination, should we not just stop vaccination after this first one and really say, well, let's wait a while before going for the second vaccination, or even skip the second?
Yeah, I mean, for me, again, these are all very difficult questions. I mean, for me, my general advice to, I'll give you an example. I have a patient who has chronic interstitial nephritis, and it is very causally linked. 2 of her relapses to an influenza vaccine in the past. And she, said, I'm worried that the same thing's going to happen when I get my COVID vaccine. And I said, look, if you get a relapse, we know how to deal with that. If you get COVID-19, we don't know how to deal with it as well as we know how to deal with an interstitial nephritis flare. So we can get your kidney back. We might not be able to get your life back if you get a severe COVID-19 infection. Especially with her, because she was on a low dose of maintenance immunosuppression. So, to me, I feel like we still need to say the priority in treating our patients around the question of vaccine is to make sure they're fully vaccinated and the risk of COVID-19 infection is as low as possible because they've received the approved route of vaccination. So I would not shortchange or reduce their vaccine administration, for any reason. I really, again, as I've said to anybody who's been vaccine hesitant, it's almost impossible to die from the COVID vaccine, and it's, as we know, there are millions and millions and millions of people who have died from COVID itself. So I would go full steam with the vaccine profile, even in a patient who's had prior, flares of disease after other vaccines. I think you have to prioritize the protection against COVID and significantly, which is a significantly higher risk to die of COVID than to get one of these disease flares.
Thanks a lot for this very clear statement. I think that's really helpful for us and for our patients. So my last question, actually, now we see all these reports, and I think it's hundreds or even more of reports, and the current issue of Kidney International has, I think, 12 or 15 on its own. But my gut feeling is that we see much fewer reports on transplant patients who have, after vaccination, acute rejection. Is this kind of reporting bias, or may this refer to some other immunological processes? Do you have any idea why we have this shift towards really autoimmune disease and not so many rejections, at least reported so far?
It's a great question. I have not really kept very close eye on that, but like you, I have not seen, increased reports of rejection after the vaccine, or with any vaccine. That has not been something that I've seen in the past with other types of vaccines either. So I think there's probably a little bit of a selection bias in that transplant patients who get vaccinated are the ones who are probably the most compliant with their maintenance immunosuppression. So less likely to have rejections, because there's probably a lot of rejection that's occurring just because of non-compliance with the immunosuppression. But you're right. You would think that if there's some sort of huge, influx of inflammatory cytokines that are happening after a vaccine, that's a potential route for these glomerular diseases. Why are we not seeing that manifesting in some degree of transplant complications? But I haven't seen it either, so it's very interesting.
So thanks a lot. This was really fascinating talking to you, and thanks also for summarizing all of these case reports. I guess it's so important that somebody really kind of sums up all the evidence that's out there. Otherwise, we are somewhat lost with all the literatures. So we are looking forward to reading more from you in the next months to come. Thanks again. Have a nice afternoon in New York City, and see you hopefully soon. Thanks.
Thank you. Thank you again for having me. It was a real pleasure talking to you guys. Thank you.